Well, while we're waiting, I want to express my gratitude for the invitation. It's really wonderful to be here. This is my second time in BIARRITZ at the THS meeting. I want to thank Jean-Pierre and the organizers of the committee, and to thank Esther and Naida for their support in making it possible for me to be here. So you'll have to excuse me. The monitors in front are not working, so I'll be turning my head a bit to the side so that we can do the presentation clearly. I have no conflicts to report. I do work at the University of Pennsylvania in Philadelphia. The program says I'm from Bethesda, but that's an error. I am from Philadelphia. And I work at the Treatment Research Institute as well, which is a nonprofit research organization dedicated to the translational research to promote science-based interventions in policy and treatment practice. In the talk, I'll quickly go through these points, but I'd like to give you an overview of my talk. I give my perceptions on the current HIV epidemic as it relates to substance use, and talk a bit about the importance of viewing addiction as a chronic medical problem as opposed to a behavioral or a criminal problem in the fight against HIV and HCV infection. I also want to talk a bit about what has become a current theme in HIV prevention, certainly in the United States, which is the concept of treatment as prevention, that we can eradicate the HIV epidemic by identifying as many people as possible who are already infected and getting them into treatment and keeping them into treatment. This has important implications for substance abuse interventions as well, because historically we've focused HIV prevention on reducing injection-related behavior. We have a lot of data over the past 25 years to show that to prove the concept that effective treatments are HIV prevention. And most of these data come from studies of methadone treatment, although there's an increasing number of studies looking at Suboxone and buprenorphine treatments. And I should say that on Friday, Don Desjardins will be giving a talk that has done the most comprehensive review of these articles and has recently been published. So despite all of this evidence, there's still a huge need to expand the opportunities for people at risk because of their drug use to gain access to effective evidence-based treatments. And there's a need to expand treatment options. And now, as this session is kind of highlighted, there are a number of new treatment delivery strategies, number of new formulations of medications, and some medications that really haven't been tried seriously as HIV prevention interventions. So again, that provides us with more opportunities, I think, to expand treatment as HIV prevention. And finally, I'll talk just briefly about the need to integrate substance abuse treatment into HIV care. There's been a lot of talk about this over the past 5 to 10 years, but relatively few demonstrations of its efficacy. And I'll talk about a study that's taking place in the GoVAP clinic, and it's about to start collecting data in Ho Chi Minh City, and I'm happy to say that our co-investigators and colleagues from Ho Chi Minh City are here with us today. Very briefly, this is the most recent UNAIDS report. It was published a couple of weeks ago. It estimates, and it's a crude estimate, but it estimates that there are about 35 million people living with HIV infection. This actually represents a decline of about 5 million people from 10 years ago. So I think the data is increasingly painting the picture that the total number of cases of HIV infection is on the decline. It's slow, but we've kind of peaked, and I think we're now seeing reductions in the global burden of HIV infection. But again, these numbers are very imprecise, and they are dependent upon regional and country estimates that are often quite inaccurate. It is important to note that most of the cases of HIV infection, the majority, are in sub-Saharan Africa, which has typically not been considered influenced by substance abuse. And that's another point that I'll talk about later in the talk. It's estimated there are even more inaccurate estimates of the number of people who are infected as a result of injection drug use. It's common to hear reports that approximately 10%, approximately 3 million people living with AIDS were infected as a result of injection drug use. Outside of sub-Saharan Africa, which is, as I said, typically considered a heterosexual epidemic, the rate of infection is believed, from injection is believed to be much higher, about 33%. But importantly, there's no estimates at all of the major role that's played by alcohol and other non-injection drug use. And to me, this represents an important scientific, but also public health opportunity, because we know for certain that there are many infections that are attributable to behaviors that occur following the use and abuse of alcohol. And to highlight this point, I just want to show some data from the largest study of men who have sex with men that followed about 4,000 uninfected men for 4 years. And when the study was finished, it looked at the factors that best predicted who became infected during the course of the study. And as you can see, heavy alcohol use, amphetamine use of any type, this is not injection, by the way, and alcohol or drugs before sex were actually the 3 strongest predictors of seroconversion during the course of the study. And again, none of these were injection-related transmissions. These are sexual transmissions that occur as a result of or in combination with the use of alcohol and other substances. And again, this represents an important opportunity, I think, for our medication-assisted treatments, particularly naltrexone, which has been not used very often at all in HIV prevention. And Dr. O'Brien will be speaking about that in a few minutes. So as I said, in order to understand my understanding of the epidemic and the role of drug use, it's critically important to view addiction and substance use disorders as chronic medical conditions. There's no cure, but we can manage these conditions quite effectively in most cases with the use of medications and behavioral interventions and counseling, medication-assisted treatments. And it just recognizes the fact that these disorders have biological components and they have behavioral components that both need to be attended to in order to achieve or maximize our success in treatment. And when we do have effective treatments, we can expect that injection-related risks will be reduced, that reduced sexual transmissions will occur as well with effective treatments of alcohol and other non-injection drugs. As was mentioned earlier, we have increasing evidence that people who stop using drugs and who are in drug treatment have improved adherence to antiretroviral medications and are more likely to suppress their HIV virus, which is the cornerstone of the strategy of HIV treatment as prevention. And so in each of these are each outcomes or targets of effective substance abuse treatment. And this final point of treatment as prevention was highlighted in the HPTN-052 study that was reported recently, which showed the 96% reduction in transmission of HIV among people who were started early on antiretroviral medications. And this has led many prevention efforts to be focused on the treatment cascade, as it's called. And this is just some data from Philadelphia, which shows that of all of the individuals who are believed to be infected with HIV infection, on the far right of the slide, you see only about 30% have suppressed viral load. And we know that at each step in this treatment cascade, substance use is an inhibitory factor. People who use drugs are less likely to be tested, less likely to be engaged in care, less likely to remain in care, less likely to be adherent to their antiretroviral medication, and consequently less likely to suppress virus. From the earliest days of the epidemic, heroin has been the primary focus, given the fact that injection of heroin was a predominant mode of transmission early in the epidemic. And this produced a number of studies that focused primarily on methadone treatment over the past 25 years. So we have a wealth of data to show that injectors who are in methadone treatment use drugs less often, they practice fewer risk behaviors, they are less likely to become infected with HIV and also hepatitis C and hepatitis B. Data from 10 years ago now has been shown, and there's been confirmatory studies to show that people on methadone treatment who are HIV positive remain in treatment longer and are more adherent to their medication and have a higher likelihood of viral suppression. So being treated effectively by methadone has both behavioral effects in reducing needle sharing, but also behavioral effects in terms of improving the effectiveness of treatment. This study of using data from the Manif cohort actually makes an important point that it's not just receiving medications that's important, it's actually stopping drug use. And we know that many people, it was mentioned earlier today, who are in methadone treatment continue to use drugs. Those people in this study showed much less likelihood of adherence to their medication. Even though they were still being treated with methadone or Suboxone, if they continued to use drugs, they were less likely to be adherent and achieve the benefits of antiretroviral medications. So I think this highlights the importance of the effectiveness of the treatment, not merely the presence of the treatment. Other data, and this is some data from Philadelphia, which shows that it's really current use of drugs that is the driving factor here in adherence and suppression of virus. It's not a lifetime history of drug use. It's not your lifetime diagnosis of dependence. It's what you're currently doing. And I think it encourages all HIV clinics to periodically and systematically screen for substance use. So despite all of this evidence, the access to treatment is incredibly small for most drug users in the world, and particularly, not coincidentally, but particularly in places where the HIV epidemic is the strongest. And this data reported by Mathers just tries to map out the availability of various types of drug treatment. The countries shaded in red have no access to any of the opiate substitution treatments. So this reality prompted several years ago the initiation of the HPTN-058 study, which was designed to test whether or not the 3 times per week dosing with Suboxone, with buprenorphine and naloxone, could result in reductions in HIV incidence and mortality, reductions in opiate use, and reductions in injection risk behavior. There were 1,250 subjects that were recruited from 4 sites in Thailand, or 1 site in Thailand, in Chiang Mai, and 3 sites in China. 2 were in the Guangxi province in the southern part of China, and 1 site was in the far western province of Xinjiang in the city of Urumqi. And injectors from the community were recruited and randomly assigned to one of 2 treatment strategies. The short-term arm, as it was called, received a 3-week detoxification, followed by 1 year of drug and risk counseling. Those who relapsed were invited and able and encouraged to have a second detoxification after 6 months. The long-term arm received the Suboxone 3 times per week for the entire year, along with the exact same frequency and type of drug counseling. We used buprenorphine, naloxone, the Suboxone tablets, which has already been well described here. But I think what's important for this presentation is the fact that, to my knowledge, this is the largest study of 3 times per week clinic-based observed dosing. So unlike methadone, which in these countries required a daily attendance at the methadone clinic, participants in this study were expected to attend the clinic 3 times per week for their medication, as well as periodically, once a month for the first 3 months for their counseling session, and then monthly for the remainder of the year. I'm going the wrong way. Okay. Okay, so I must say that the study stopped early because the incidence rate of HIV infection was extremely low. In the years, there 8 years previous, in these same communities, we had seen incidence rates of 3% and 9%. These are 2 of the areas in China per year of HIV infection. In this study, we saw a combined total of less than 1% per year of HIV infection. So the study had to stop early because of our primary endpoint being futile. However, we got important data on the continued I'm not sure where I'm supposed to be pointing this. That's okay. So when we looked at the data, we saw that during the treatment year there was a dramatic reduction and significant reduction in the frequency and the high rates of injection during the month prior to assessment. The yellow bar there just signifies the beginning of the tapering and the end of the treatment phase. The self-report data on continued injection was very similar to the urinalysis data, which showed about 40% opiate positives, 40 to 50% opiate positives in the long-term arm, and about 80% opiate positives in the short-term arm, the counseling-only and detoxification arm. What surprised us was the speed with which people returned to opiate use upon the tapering of the Suboxone at the end of the treatment year. We had expected a more durable effect and a slower return to opiate use, but that was obviously not the case. Within the 1 month between the two blue bars there, we saw a dramatic increase. As soon as the tapering began, people returned to opiate use. I'm going the wrong way, sorry. So anyway, these data also showed that in both arms we saw a significant and sustained reduction in needle-sharing behavior, the most prominent risk behavior measured in this study. This could be attributable to the fact that both groups received behavioral and risk counseling, although only in the long-term arm did people actually reduce opiate use, which can be expected to have more profound effects on prevention, and certainly those who are already positive. So anyway, I'll begin to summarize now in the next few slides. Effective treatments for substance use, in my interpretation of the literature, recognize addiction as a chronic medical condition. They use both pharmacologic and counseling interventions, are accessible, acceptable, and affordable. And drug treatment prevents HIV transmission by reducing the frequency of substance use. Fewer injection-related risk behaviors, fewer infections, increased access and retention and adherence to medication in HIV care. In order to maximize and to really expand the coverage of evidence-based treatments, we need to make sure that the treatments are led by addiction medicine. We need to expand the number of medication-assisted treatments. We need to treat alcohol and other non-injection drug use as we have treated opiate injection in the first 20 years of the epidemic. And we need to use new extended-release formulations and integrate these substance abuse treatments into HIV care. And it's really this final point that is being demonstrated in the study that I mentioned that's taking place in the GoVAP clinic in Ho Chi Minh City. This is a collaboration between Esther, NIDA, the Ho Chi Minh City PAC, and the University of Pennsylvania. We're introducing both methadone and Suboxone into an active HIV clinic that treats many HIV-infected injection drug users. And this is this is a services research study, operational research, and we're going to be focusing on looking at the factors that influence access, acceptability, and impact on drug use. And obviously, we're going to be measuring retention and adherence in HIV care. So I'll end here. Thank you very much.
Merci bien. Est-ce qu'il y a des questions? Oui. Micro.
Oui, bonjour. Voilà, je voulais savoir dans quelle mesure vous dites on est surpris qu'il y ait une rechute rapide à l'arrêt du traitement.
Sorry. No. Can you repeat the question?
Oui, alors je disais que vous dites que vous êtes surpris dans l'étude qu'il y ait rechute à l'arrêt du traitement. Et voilà,
Wow.
donc j'aurais voulu des explications puisque...
I didn't say that I was surprised that there was a relapse. What I said was I was surprised with the speed with which the relapse took place within 2 weeks. We had many people who had sustained abstinence from opiates during the course of the 1 year of treatment, and who were prepared in the counseling sessions and from the very beginning of the study prepared to taper and return to the community and, to return to their lives without the assistance of the treatment program. We expected there would be a longer interval between the relapse than what was observed. And that was my point, was the fact that, and I think this is not a surprising finding to many, but we had hoped that the power of the counseling and the behavior change would be more sustainable, and it wasn't. And I think it's convinced me to be a stronger advocate for, a long-term access to these medications.
Ça confirme tout ce qu'on sait sur ces maladies chroniques et l'importance de traitements longs. Encore une autre question? Oui? Micro.
Dave, that's an excellent presentation of the value of opiate substitution treatment. Would you care to comment on the issues related to trying to get the medications into these various countries?
Well, it's a political process for sure. But, I'm often reminded of the fact that even in counties that surround Philadelphia, there's not access to methadone maintenance treatment. So I'm not sure that there's a simple political answer to this other than the persistence of doing research like we do to show the importance of this work. I'm not naive enough to think that data alone will change policy. But you could not find a less expensive treatment than methadone. The medication is very inexpensive. It's a little expensive to deliver the methadone. But I really don't have any solutions other than we're making slow progress, and hopefully that will continue.
Très bien, Professeur Kleber.
Yes, again, an excellent talk, David. The talk I gave 2 years ago at this meeting gave very convincing evidence that there's an extraordinarily high relapse rate after detox, a very, very high relapse rate after you stop maintenance treatment, and yet, in spite of all that data, why is it, especially with a chronic disease like HIV, that people aren't using the current scientific findings about maintaining people on these substances?
Well, I think that will, that is the message of this study. That's the message of many studies previously. Again, I don't know how to provide any more clear data to policymakers about these effects. I do know that, for example, our work in Indonesia has confronted issues of cost, that it's much cheaper to do some of what's defined as harm reduction programs as opposed to invest in longer-term treatments like methadone or Suboxone. The fact is we need both, and I think we've allowed our political systems to sometimes, place the dollar value as being the primary, or the short-term costs as being the primary deciding factor, when in fact the long-term costs are, I think, clear as well.
Encore ici, une question?
Oui, oui, merci pour cette passionnante présentation. Et je me souviens effectivement de la présentation d'il y a 2 ans de Herb à propos de la méthadone terminable ou interminable, qui mettait bien en évidence en fait l'intérêt des traitements médicamenteux dans la prise en charge des toxicomanes et des gens dont on s'occupe ici, et de la persistance, de la possibilité pour les patients d'avoir... Alors, j'ai 2 questions concernant le profil VIH des gens que vous avez étudiés et qui font partie de votre étude en Asie, pardon, excusez-moi. Est-ce que vous avez des chiffres de séropositivité à l'entrée de l'étude VIH? Et est-ce que ces chiffres sont en accord avec ceux que vous avez présentés au tout début, c'est-à-dire des chiffres qui sont relativement optimistes pour l'Asie du Sud-Est, et notamment pour la Chine, qui était en jaune dans votre présentation? Est-ce que les toxicomanes que vous avez soignés en Asie avaient un taux une prévalence aussi, on va dire, basse? Et 2, est-ce que vous avez, c'est une question subsidiaire, observé un changement dans la prévalence? C'est un peu la question posée de Chuck à l'orateur précédent. Changement dans la prévalence du VIH dans cette population? Voilà. Merci.
Yeah. I probably did not make it clear, but to be in this study, every individual had to be an injector dependent on opiates and uninfected with HIV. So no one began the study infected. In our screening process, we identified it varied from site to site, but from about 5% to 15% prevalence in the injectors that we screened for the study. And what I showed you was the very low incidence of new infections during the course of the 2-year follow-up of these participants. And I do think that we worked as a requirement, as an ethical requirement, we worked in cities that already had methadone treatment established. And I think that has kept the rate of new infections in the community at a low level. And